Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Prostate cancer is common, and unfortunately, it's more common and often deadlier among Black men. Today, we are meeting a man who found out he had prostate cancer and at the same time learned he didn't need treatment right away. We'll hear what it's like to live for years under active surveillance and how doctors knew it was finally time to get surgery. But first, let's get to our morning rounds this morning. Cancer experts from around the country are collaborating this weekend at the University of Kansas Cancer Center. Physicians, pharmacists, and other oncology pros are meeting in Kansas City to learn the latest on immunotherapy and cellular therapy. The ICE-T Symposium is led by Dr. Al-Ala Abdallah, an expert in multiple myeloma and the director of the Cancer Center's Plasma Cell Disorder Program. Dr. Abdallah, good morning. How are you?
Good morning. How are you doing?
Very well. Good to have you with us today. We are what they're calling kind of in the middle of a cellular tsunami. A lot of cellular therapies are on the market right now, and so many more are being developed as we speak. Some of our viewers are familiar with one form of cellular therapy called CAR-T. In your words, can you explain and define what cellular therapy that is?
Absolutely. I think this is a very important era for our blood cancer treatment and maybe solid cancers as well in the future. The cellular therapies is something, I think it's an innovation of therapy that actually lead to use your own immune system to attack the cancer cells. There's two major parts, and I think there is going to be more parts in the future, but the two major parts that we focus on, and especially in our symposium, is the CAR T cell that a lot of people are familiar with. And the CAR T cell is your own T cells that we extracted from your body, through an IV. We manufacture it by putting a laser tag or a GBS. That then after that we produce millions and millions of these CAR T cells or T cells that are modified and reinfuse it back to your body that will go back and attack the cancer cells using the laser tag. The attack is the same thing as other T cells do, and that really have really significant impact in terms of like treating many cancers and curing it in some type of blood cancers. And we're seeing a lot of efficacy in these type of cellular therapies. Other cellular therapies now we're seeing is the bispecific, which is antibodies. Instead of actually taking your T cells out, we inject a product that will play as a moderator or that mediates to your T cells to direct it to attack the cancer cells at that time. So these are really exciting time, for us, to see these cellular therapies and the type of cellular therapies that we are actually using to treat a lot of blood cancers. And in the future, we're seeing a lot of clinical trials to see hope in treating solid cancers as well.
And you're bringing together experts from around the country. What types of things are you learning from each other?
I mean, I think one of the major things that we're learning is the latest clinical trials for each specialty in the blood cancers and solid cancers and maybe non-cancers as well. But more important thing is that access to these treatments. That's the whole purpose of these conferences is to make sure that there's access for majority of the treatments, using it more outpatient instead of inpatient. So this is our biggest goal in this Congress.
We spoke with one of your patients who says that CAR T cell therapy helped her fight cancer, and she was able to access it early thanks to a clinical trial.
The older treatments that are available that you get, I'd gone through a lot of those already. So it was like, searching, and talking with your doctors, about, okay, what can I do that I haven't done already? And clinical trials is a natural thing to look at next because those are the drugs that are coming up. I also think it's important to further research, for others too. So part of it's a little altruistic.
Dr. Abdallah, if someone out there is curious about a clinical trial, how do they go about finding one?
Absolutely. I mean, I think that's a very important thing. And I think, we have a great website for the myeloma and other blood cancers that, we recommend to access it, and there is some contact numbers as well, emails that they can actually reach out in order to have a specific question about the clinical trials. And that will be more, advisable for a lot of patients.
Before we let you go, I have to ask, what excites you about the future for cellular therapies?
I mean, I think the future of that is that, most of it is a very tolerable treatment instead of the old chemotherapy fashion of the chemotherapy, and very effective treatment and showing a lot of promises. And I think it's, leading us to curing some of the blood cancers, which is a very great promising for a lot of our patients.
Oh, and I know this is a team effort. Who helped you lead the symposium?
Well, absolutely. I have to give a big credit for both Dr. Mahmoud Jafri, Zahra Mahmoud Jafri, and Sheen Ahmed. Both of them are the directors of the ICT conference. They're actually the leaders for that. They founded it as well, and they help to put all of this together.
All brilliant doctors. Thank you guys so much. Appreciate. Good to see you today.
Thank you very much.
Well, we are joined once again by Dr. Will Parker, a urologic oncologist here at the University of Kansas Cancer Center. Welcome back.
Thank you. Thanks for having me again.
Good to see you. We're also meeting one of Dr. Parker's patients today, John Clay. How are you feeling this morning?
Feeling great. How about you?
I'm feeling really good. It's Friday. We're so glad to have you with us today.
Oh, yeah. Glad to be here today.
So, John, take us back to your diagnosis. How did you learn that you initially had prostate cancer, and when was that?
Well, it was in 2018, and what I did was, I usually go get my physicals yearly, and what I had was, I had the doctor I had a physical, and she did a PSA physical, and so the numbers came off a little off. So once the numbers came off, they sent me to another doctor, and they did a little diagnosis, and then I had a biopsy, and then that's when they found the cancer.
What I like that he said, Dr. Parker, is that he was getting his annual physical,
Yes,
and he was staying up on his health. That's really good.
Right.
We don't always hear that, so that's good. That's very good news. I want to show some early warning signs of prostate cancer. Dr. Parker, let's go through those as we show those on the screen.
Yeah, so I think the first bullet's the most important. So most prostate cancer has absolutely no symptoms. The vast majority of men I see come in similar to John with just an elevated PSA, feeling fine, doing fine, and then suddenly there's this blood test that's a little bit off. There can be other signs and symptoms like problems urinating and blood in the urine and semen, but those are very rare to be specifically associated with prostate cancer.
Were you feeling any symptoms, John? Do you remember?
Well, didn't have any symptoms at all. Really felt fine, and so once the numbers changed, they sent me to the first doctor, and so then that was it. And after going through that, they sent me to then that's when I got Dr. Parker was my second referral, and then that's when we kind of worked together, try to work through things and see what's going on. So, but never had any symptoms at all, nothing.
So, Dr. Parker, we hear that story where, again, like you said, almost no symptoms from patients, which is where early screening and detection, that's where that helps. So let's go over some of those early screening guidelines here on the screen.
Yeah, so for average risk men, which is somebody who doesn't have a family history, typically white men, we should start at 45 with a PSA test. Black men, men with family histories of prostate cancer, also just enrichment of cancer, so colon cancer, breast cancer, ovarian cancer, they should really begin at 40, and it should be a PSA blood test. There is debate about the rectal exam. Certainly the rectal exam is a way to feel the prostate and see if there's anything abnormal. I think there's value in that, but the PSA test is really the cornerstone of screening.
Any data about how many men are actually getting screened?
So there is, and it's kind of sad data. So the CDC publishes some data about cancer screening rates. It's actually been declining. So in the early 2010s, the rate was about 70%. It's now dropped to about 60% of men are getting screened for PSA.
So in John's case, he learns that he has cancer, and I think most people naturally want to get cancer treated as soon as possible. Why is prostate cancer different in some cases?
So first, it's important to recognize that prostate cancer is a spectrum of disease. So there are men who have very low-grade cancers that are unlikely to ever cause harm, and then there are the other ends of the spectrum where the disease is more likely to hurt somebody over time if left untreated. And so there's this kind of almost odd dichotomy in prostate cancer in that at the lowest grade, to our knowledge, it doesn't kill anybody. And so grade 1 prostate cancer is really a non-lethal disease. So,
John, had you heard of active surveillance?
Have not heard it at all. And really, I was really be honest, I was nervous about that, of course. And after talking to some family, they like, hey, you need to jump on it. But I was patient, prayed about it,
Yeah.
kept spiritual, prayed, and I said, well, I trusted Dr. Parker. I think he was God sent, and I met him, and he just kind of winged me in and talked about it. And then I said, well, let me try this. And so that's what I was being patient with that, and because you don't want to do something that you don't have to do at the time. So I was being patient. I said, let me just wait, and that's kind of where it went.
I was going to ask you how you wrapped your head around it, but yeah, you don't want to do something you don't have to do.
Right.
But when you're talking about cancer, it's that feeling of get it out, and I want to get it treated
It is, because once you hear the big C word, it's fear. Hey,
Right.
I'm in trouble with that situation. So.
But then you hear, wait, it's not like it's something that we can kind of hold off on. How do you have that conversation though with somebody who says, I don't want to do that? That's got to have somebody who goes, I don't like the idea of that. I don't want to wait.
It's a lot of education. So, I think first and foremost, my job when I'm seeing somebody the first time is to try and educate them about what it is that I know about their prostate cancer, what they should know about their prostate cancer, and how that translates into the recommendations that we're going to make. And what I find is for most people, as John said, there's this real fear about the moment you hear the word cancer, and a lot of it is kind of unpacking what that fear is and why, at least for some men, it's not a real concern.
So what does active surveillance, what does that entail? What tests are being done? How often?
So first off, it's active. There are parts and pieces to it. So it's PSA testing every 6 months. Biopsies of the prostate are done initially at about a year to a year and a half, and then if things look good, we start to spread out the biopsies to somewhere between 1 and every 4 years.
Okay, so this went on for 7 years.
Correct.
Is that usual, unusual?
So most men, so first off, when we put men on active surveillance, about 25 to 50% of men will eventually need treatment. So it's not a guarantee that people are going to live out the rest of their life without having to do something. A lot of those men, that 25 to 50%, find that their cancer is more aggressive within the first year or two. So a lot of men don't stay on surveillance for a long period of time if they're going to come off. Now, what's unusual is when you go a really long time, it kind of surprises you when somebody has a change. So this is a little bit more unusual, but also the reason why we do surveillance.
Yes, exactly.
Yeah, so 7 years is going on. How are you feeling during this time?
Feeling good. I really didn't skip a beat. It still worked. Still, me and my wife traveled a lot, and so we just kind of kept living. And really didn't have much anxiety. I don't know. Maybe it's because I prayed about it, and me and my wife had a very positive. My wife was very positive, and kind of with us, we just kind of kept living. You can't just let it slow you down. You got to keep on living. And then anytime you go through a situation, you have to be willing to fight for whatever you're going for. You can't just stop living because of the situation.
And tell us about your family support here.
My family, my parents, of course, they've been very supportive. My mom, dad, sister, and brother, and of course the main, because we don't have any family here, of course, in Kansas City. So my main cornerstone is my wife here.
Did you get married during this time?
Got married. Yeah, we got married, kept living, kept traveling. We never slowed a beat.
Well, that blows cancer out of the water.
Oh, definitely.
Who cares about cancer when you're getting married?
Yeah, so we didn't want to slow down the process of,
life.
Life.
Yeah,
So
for sure.
So one thing about having cancer itself, it's not a death sentence. You have to be willing to jump on it and be active. It's kind of a process. You have to be willing to go through the process.
So, Dr. Parker, then what key factors tell you that it's time to stop monitoring and now start treating? What's happening?
So most of the time it's going to be a change in the biopsy. So PSAs help give us a little bit of a clue if something's going on. So if I'm seeing the PSA start to rise at an unnatural rate, then maybe we think that something's changing. But ultimately it's a change in the grade of the cancer on a biopsy.
So what's that conversation like? You tell John, okay, it's been all this time has gone by and now it's like, okay, that conversation has to be had.
So, it's tough because, again, when we've gone a long time, it's really a surprise. I think, first and foremost, as I said earlier, it's really what the goal of active surveillance is. The goal is to identify when a change has happened and we need to treat it. And so I think starting by framing it in the context of this is why we do this. And then, acknowledging the things that were able to happen because of active surveillance, right? You got married, you lived life, you had, this is really what we want as life goes on. And active surveillance allows us to do that.
Yeah. And does active surveillance mean that treatment is basically inevitable? It's coming at some point, or?
No, again, about 50% of men never need anything done.
Okay.
But the other term we'll use, particularly at the start of active surveillance, is deferred intervention. So to set that kind of mindset of, well, I hope we never have to do anything. The real goal here is to delay doing something for as long as possible to live as full of a life as you can.
How'd you feel about that? Emotionally, physically, now you're starting treatment?
Once I started treatment, still I didn't have much fear. And I'll be honest, I was more nervous about the catheter, you know what I'm saying,
right,
than the treatment. So I wasn't never nervous about the treatment per se, just the after effects. But it went pretty smooth. It wasn't that bad, and having, like I said, I had the support of my wife and family and all that, and just never, and of course, spiritually, that helps you keep grounded. Whenever you're going through something, you have a spirit, and I think in life you have a process, you know. It's just you have to pivot and do something different, and that's kind of what happened. You have to pivot, it's time to change, and then we have to do something about it.
It's a good way of looking at it. So why did you decide on surgery instead of radiation or something else? Were there options?
Did not want surgery at all. I mean, because I was more nervous of the surgery. You know, cutting. I haven't had surgery, so I was nervous about it. But and of course, that's when you have a great doctor. Dr. Parker, we kind of have a friendship. He let me know, hey, John, you have to. And I was kicking and screaming, didn't want surgery. And so, but once he told me, he said, hey, this is your option, because I had an enlarged prostate too. So I had to pivot and change, and that's when we went on the surgery. And he even, Dr. Parker, because he's very open, he said, I'm going to send you to a what you call the
radiation oncologist.
Radiation. So once he sent me to him, he kind of said, hey, surgery's for you. I said, well, we don't have any choice. We have to have surgery.
Okay, so no choice in this situation where maybe there would be options, no option
Well,
here.
no, there was a choice.
It was a
It's just maybe not as good of a choice.
Got it. Okay. So you helped guide that choice
Correct.
a little bit.
Right.
Okay.
Yes.
That's what you're there for.
Correct.
Okay.
Because you got to look at your options, you know.
Gotcha.
Yeah.
Yeah. Okay. So prostate surgery, though, these days almost done robotically, so
Yes.
this makes it a little bit maybe more pleasant.
Yes.
Maybe when you're describing the process to someone like John, maybe it makes it a little bit easier. But what does the robot allow you to do that maybe you couldn't do and maybe you can't see? You know, allows you with your hands and your eyes, and you're doing this right here, as we can see on the screen. Kind of cool.
Well, it is very, I mean, I think it's very cool.
Very cool.
First off, I think one of the most important things is it's not a true robot, so it's not like I hit autopilot, go take out the prostate, and the machine does it. What this allows us to do, as you could see kind of on that video, is it translates what I'm doing with my hands into the robot, into the machine, and so it miniaturizes my movement. So if you think about when we would take out a prostate with our hands, I have my hands and they're in removing the prostate. They're in between my eyes and what I'm doing, so my hands are in my own way. I can't necessarily see what I'm doing, so the surgery was done a lot by feel. And also my hands are a lot bigger than the robot's hands are.
Okay.
So it was a lot cruder in terms of that. So what this does, it improves the recovery both physically, so how fast you feel normal. I mean, a traditional recovery from an open surgery would take 6 to 8 weeks. Now men feel fine within 2 to 3 weeks.
Yeah.
Yeah. How was your recovery like?
Recovery was real good. I guess probably about first few weeks, I was, you know, pray for my wife. I was the worst patient in the world. Got on her nerves the first few weeks, but you know, she bared with me. Because, you know, no man, you know what I mean, we don't enjoy surgery. It's not fun, and we don't like the pain, but it wasn't, I said over the first couple of weeks of the pain, then it went away, and then after a while, I got back to work in about a month.
So you were kind of a pain on your wife? Is this what you're telling me?
Yeah, I could be a, you know,
Oh,
bad patient.
You could be that way sometimes. Okay.
So, but,
Guys are the worst.
guys would be the worst patients.
Guys are the worst like that. Okay. Dr. Parker, surgery, as we've talked about options, not the only option. When does radiation, though, make sense?
Well, I mean, I think it depends on the individual and what their goals are. The side effects of surgery and radiation are very different. You know, radiation causes more kind of irritative urinary side effects. There also can be the use of hormonal therapy, which is anti-testosterone. So we kind of put men into menopause, essentially. And so depending on what the patient's goals are and what they want to avoid, honestly, that's when radiation may make more sense than surgery.
And there's another option using ultrasound, no surgery, no radiation. How does that work, and which patients should consider it?
And so this is called high-intensity focused ultrasound, which is an ablative modality. So instead of treating the entire prostate, for men who uniquely are diagnosed with a very localized prostate cancer in the prostate, so just to one area, and a lower grade cancer, focal therapy offers the option of minimizing the burden of treatment, so the number of side effects, the recovery, while still offering some degree of cancer control. It is a very narrow window of people who meet the necessary criteria to do that treatment, because it is a lesser treatment in terms of cure than taking out the prostate or radiating the prostate.
Well, be sure to ask your questions. You can use the chat on YouTube or Facebook, or you can email the Medical News Network. All that information is right there on your screen. Let's talk about the risk factors for those who are watching and listening. Very important. So walk us through those that we see there on the screen.
So first off, men over 45, not necessarily a risk factor. It's just we know that the incidence of prostate cancer increases with age. So as we age, our rate goes up. Race, definitely black men are at a much higher risk of developing prostate cancer than other ethnicities and racial groups. Family history, as I already talked about, not just prostate cancer, but other cancers. There are also genetic syndromes that we know about, like BRCA or BRCA, as we're familiar with in breast cancer, also causes prostate cancer. And so families who have known genetic predisposition. And finally, military service. So we know Agent Orange exposure in the Vietnam era. There's increasing evidence that kind of burn pits, chemical exposures, firefighters are at increased risk for the same reason.
So what should providers be doing? What should they be doing better at when it comes to educating patients? You talked about it's about education. So is there anything that, patients should be looking out for? Maybe patients should be asking their doctors when it comes to that, especially, African American men when it comes to that, because you saw that on the list. What should they be asking?
Well, I think what providers need to do is just check PSAs. Asymptomatic diseases are tough because we're the ones who are looking for it, so it's not an initiated screening in the sense that somebody comes in with a problem and says, hey, why am I suffering from this? So I think the first thing is we actually need to educate providers. This is the why we do screening. This is what needs to happen. Men just need to know, am I getting screened or not? Because they're not often told, this is the panel of tests I'm doing, this is why I'm ordering all these things, and what is in the panel. And so to know, is that PSA there or not?
And do we know why Black men are more likely to get prostate cancer, or why it might be more aggressive?
So we don't fully know all the reasons why. We do know that there's some enrichments of genetic risk. So there are some genetic mutations that are more prevalent in Black men. But we don't fully understand why. This is one of the challenges with prostate cancer, really any disease that's very common. 1 in 8 men get this disease. So if you have a disease that's incredibly common, you can find an association almost with anything. So for instance, there are a number of studies about coffee consumption. So I'm an avid coffee drinker. There's a study out there that shows that if you drink 7 cups of coffee or more a day, your risk of prostate cancer goes down. And another one that says if you drink no cups of coffee, your risk of prostate cancer goes down. So it's tough to figure out why these things happen. The reality is we just need to acknowledge it does, and there are men who are at a high risk and they need to be screened.
Did you know that you were at higher risk?
Well, I didn't know till Dr. Parker told me it was a high risk of a African American, so I wasn't really aware of. And also when I did some update online, online you looked at it and it gave you a situation, kind of telling you how. I don't know why, of course, and it may be healthcare that maybe we're not accessible to healthcare. Sometimes the community is not able to get health care, like a lot of good quality health care,
Yeah.
And so that may be part of it. Sometimes also, me coming from the South, sometimes you realize that sometimes the stigmatism to come along with, hey, how things were done in the past. And sometimes people have a enigma about doctors. They're very nervous about doctors, so that makes them scared to go get treatment.
Yeah, and I'm glad you brought that up, because you talked about that. That's
Right.
something that you talk about. And do you feel comfortable talking with your peers about your family, your friends?
Very much.
Do they ask you about prostate cancer, and do you talk
They
to them
really
about
don't,
getting your PSA checked?
and even men in general. A lot of times, men we're very private with our. When it comes to your body, you're just private. That's just a normal thing. But I think we have to. I'm more open now than my family would be. You know what I'm saying? Because we were raised. The grandpa didn't say nothing about it, and we kept it to ourselves. So I'm learning that it's important, because you don't realize who may have the same situation.
Do you have sons?
I don't have any sons.
Have any
Just
sons?
daughters, just 3 girls.
Yeah,
So,
but you find yourself. It's not easy to talk about.
But it's important to let people know, because you never know. Because you may tell. So I'm learning to communicate a little bit more, so people know. Because sometimes people don't know about prostate. I didn't know anything about it. So you have to know so you can be on top of it. Because it's important to save your life.
But you were getting your screenings and you're getting your physicals, and that says a lot.
That's what I've done, but a lot of people do not do that.
I know,
So.
but hopefully they will after hearing you today.
That's
so
right.
That's really great.
That's right.
Let's get to, we've got a couple of questions from viewers this morning. Angie wants to know, how do you know which cancers are aggressive, or if somebody has an aggressive type? Is there like a test or something?
So when we do a biopsy and it comes back, it doesn't just say prostate cancer. It'll have a grade associated with it, which is a numerical scale that runs from 1 to 5. And so the higher on that scale, the more aggressive it is. So that's how we know.
Okay. Marion wants to know, did John have a family history? We know you didn't talk much about it, but did you know of any?
My grandfather he died of prostate cancer. And so I knew he died of it, so that's the history. I knew a little bit about that. We didn't know a lot about it even with that, but I just knew that's when he passed away.
You just knew he passed away, but never really talked about it, probably.
Never really talked about it, not much, no.
What do you want the big takeaway from your story to be?
Well, my big takeaway is it's important to get your physical and make sure you get checked out. Make sure you get your physical. whatever your spirituality may be, make sure you stay prayed, whatever it takes. If you have cancer, make sure you have an inner part of you to help you get through it. And it's not a death sentence, you know. Just because you have cancer, that don't mean you're deaf. You can fight it and be willing to fight it. That's what my take on it. So.
Great message, Don. Thank you so much for sharing your story today.
Thank you.
Dr. Parker, it's Friday. Wrap us up. What's the big takeaway?
Well, I mean, obviously, I say this a lot, be your own advocate, but I also think the important thing about this story in particular is don't put your head in the sand. So prostate cancer and cancer is scary. The reality is if you ignore it, it becomes scarier. So if we diagnose it early, get it addressed early, then men do better and have better outcomes.
And have more options.
Correct.
All right. Thank you both.
Thank you.
Appreciate you.
Thank you. Bye-bye.
Thanks to both of our guests. Thanks to our viewers for being with us. Have a great weekend, and we'll see you back here on Monday.
Join us tonight at CPKC Stadium for our next KC Current Health Awareness Night. Tonight, we're highlighting cancers affecting women and the specialized treatments offering hope and even a cure. Stop by our tent to snap pics in the photo booth and grab some current swag. See you at the match.
Coming up Monday on the Morning Medical Update, a reading coach diagnosed with cancer writes her own book about staying strong in the face of adversity. She's been through clinical trials and is now living a full life with cancer. I'm Alexis Del Cid. On the next Morning Medical Update, learn about her new job as cancer coach and the message she has for patients. Monday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.